Now let's talk about lung cancer screening, non-small cell lung cancer and small cell lung cancer screening. The guidelines are in agreement that annual screening with low dose CT scanning should be offered ages 50, this has changed, the year ages have changed, 50 to 80 for those who at least smoke 20 pack year smoking history and continue to smoke or have quit within the past 15 years. Major changes were the age and reducing the pack history from 30 to 20. Discontinue screening if quit greater than 15 years. The 2020 changes expanded the amount of the eligible screening population by 86%. So this is important when you start seeing studies like this, is that inappropriate use of CT for lung cancer screening. Only 13% of the patients who met all the 2013 United States Preventive Services Task Force screening eligibility were screened. So as providers, we're not, first of all, asking our patients enough to see if they're being screened, if they want to be screened, and then we're not having good enough discussions with our patients. We need to get more adherence to this plan so that we can catch lung cancer faster, getting a treatment plan for them. So this is a good potential for a board question, because the fact is that people are suffering harms because something we are not as providers discussing as well as we should. All right, let's talk about screening for AAA. Men ages 65 to 75 who've ever smoked. The Preventative Task Force recommends a one-time screening. Now, when they say whoever smoked, if they smoke one cigarette, no. They recommend at least greater than 100 cigarettes, that's 5 packs, who've ever smoked more than 100 cigarettes in their lifetime, and getting a screening for a AAA with ultrasound. Men ages 65 to 75 who've never smoked, recommends that you selectively offer. Okay, so you can ask them if they'd be interested in getting the ultrasound. Women ages 65 to 75 who ever smoked, there's insufficient evidence to discuss the benefits and harms for screening for AAA. Women who've never smoked, it recommends against getting the AAA screening. All right, now let's talk about screening for prostate cancer. Now this is really, we're going to call this a very highly controversial. The American Cancer Society does not recommend screening at any age because the test we have, the PSA test, is not the greatest test in the world. And you have the urologists are now saying we're seeing a lot more advanced stages of prostate cancer when we had a chance to prevent this if they had the proper screening. So this is going to be a controversy. It will end if we get a better test, and if we get better tests and better treatment for prostate cancer. So then the discussion should be, if patient has at least a 10-year expectancy, should give them the opportunity to make an informed decision with their healthcare provider after receiving information on the uncertainties and the risk and benefits of screening, and also talk about the treatment. Do they really want to get the treatment? Do they want to go through all this and get the treatment? More discussion on screening for prostate cancer. Men should receive information starting at the following ages. Age 50 for those that at least have an average risk of developing prostate cancer. Age 45, those at higher risk. Those include African American and men with first-degree relatives, either a father, brother, or son, diagnosed with prostate cancer before the age of 65. Now, prostate cancer is an interesting cancer. Is when they do autopsies on older people, older men, large percentage have prostate cancer. And we can basically say is every male has prostate cancer. Do they live long enough to experience the symptoms? And then is the prostate cancer itself, is it causing them symptoms? Just like that young man that we had who hadn't gone to the doctor, we discussed earlier in the lecture, where they had cancer that caused them to have what? Seizure-like activity. Age 40 for those with a higher risk, more than one first-degree relative diagnosed with prostate cancer at an early age. And then we have a discussion. Okay, we'll continue discussion on screening for prostate cancer. Men who decide to be screened should at least be tested with a PSA testing. Digital rectal exam should also be done as part of the screening. And this is part of this. You have a discussion if they will allow the digital rectal exam. If screening does not detect cancer, the time between substance screening depends on the blood results on the blood test. So if the PSA is less than 2.5, retesting should be done every 2 years. PSA greater than or equal to 2.5, retesting should be done annually. Screening for osteoporosis. So let's talk about if someone has risk factors. So screening for osteoporosis in all adult age 40 years and older with risk factors. So what are the risk factors? Within 6 months of starting chronic glucocorticoid therapy, and the doses are going to be greater than 2.5 a day for greater than 3 months, and repeat screening every 1 to 2 years. So younger people, if they have risk factors, the main ones being chronic glucocorticoids. Remember, glucocorticoids work. You can buy a bucket for $5, and we'll discuss how there's not enough rheumatologists in the United States, and glucocorticoids are being overprescribed, and it's causing harm, and one of the harms could be osteoporosis. So we can catch this on screening and get the right medications for them. So women 65 and older, the the United States Preventive Services Task Force recommends screening for osteoporosis women age 65 and older, and in younger women whose fracture risk is greater to equal that of a 65-year-old white woman who has no additional risk factors. Now, we talked about those people, age 40, who are at least using steroids within the last 6 months, chronic glucocorticoid therapy greater than 2.5 milligrams of prednisone daily, which is a smaller dose, for greater than 3 months. Men, their current evidence is insufficient in the balance of benefits and harms for screening for osteoporosis in men. Now, we would, once they're screened, say the woman is getting screened, repeat every 2 years. Breast cancer screening. Age, let's talk about age, let's say age out on this, is that age 75 or older, individual decision factor is based on overall health, life expectancy, and previous screening results. This is ACS screening guidelines, yearly mammogram, starting at age 40. I know it was 50 before, this has changed, 40. Before it was a discussion between ages 40 to 50, it's 40 now. Clinical breast exam every 3 years between ages of 20 and 40, and yearly after age 40. Breast self-exam, the option for women after they reach age 20. This is the Preventive Services Task Force screening guidelines. Remember, there's going to be a little bit difference between these societies. Recommended biannual screening, 2 years, and a screening between age 40 and 74. Insufficient data to recommend against or for is clinical breast exam, digital mammography, or MRI screening. All right. The digital mammography is kind of a better test, and MRI screening can be better, and there's a discussion of using this in patients who have dense breasts. Recommends against breast self-exam. This was a study out of China that showed that they were finding lumps that could cause harm in the screening process, so recommend against breast self-exam, because what is going on? What's happening is that it's subjecting women to further testing. The testing can cause pain and suffering and cost money without a benefit. Breast MRI, we'll talk about this. Used for screening in select women, young women with dense breast tissue at a high risk of developing cancer. The American Cancer Society supports breast MRI screening for the following high-risk women only: BRCA1 or BRCA2 positive status, first-degree relatives with BRCA1 or BRCA2, and the patient is untested, meaning they don't know. Lifetime risk of breast cancer in the calculator is between 20 and 25%. Radiation to the chest, when would they receive radiation? If they were getting treated for a malignancy, say lymphoma, between ages 10 and 30 years. Carrier or a first-degree relative with the TP53 or TPN mutation or hereditary diffuse gastric cancer syndromes, very specific. Continued discussion on breast cancer screening. Also, women who receive chest wall radiation, we talked about this, between ages of 10 to 30 years should get annual mammogram and MRI starting 10 years after radiation exposure. Following up after clinical treatment of early breast cancer, annual mammography. No need for blood tests, tumor markers, blood scan, or CT scan, just annual mammography. If patient develops metastatic disease, repeat biopsy of metastatic lesion to confirm diagnosis or continue hormone receptors to confirm hormone receptors, as they may be different from the original tumor. So what makes sense is that if they have recurrence and they have metastatic disease, we need to get a biopsy because it could be a different hormone marker positive than the original breast cancer. Now let's talk about overdiagnosis and screening mammography in older women. Overdiagnosis. Between ages 70 and 74, overdiagnosis can occur in about 31% of those being screened. Ages 75 to 84, 47. So this is where concerns and kind of discussion of stopping the screening because can have an overdiagnosis, meaning there's something that shows up on a mammogram. They go through the process of testing, which can be painful, costs money, takes time, and then the results are negative, and then increases in age 85 up to 54%. Screening not associated with significantly statistically lower breast cancer mortality in these ages. Screening is not associated with statistically significantly lower breast cancer mortality in these age groups. Let's talk about cervical cancer screening. Women ages 21, we're against screening. Why? They have a higher chance of clearing this out. Their immune systems are strong. Women ages 21 to 29, every 3 years. Women ages 30 to 35, every 3 years with cervical cytology alone. Every 5 years with high-risk human papillomavirus testing alone. Every 5 years with high-risk human papillomavirus testing in combination with cystology, that's co-testing. The above recommendations apply to individuals who have a cervix, regardless of their sexual history or HPV vaccination status. Continued discussion on cervical cancer screening. Women ages 65 recommends against screening for cervical cancer who have had adequate prior screening who are not otherwise at risk for cervical cancer. So if they've had the screening and they have not had any positives, recommends against screening for cervical cancer women who have had a hysterectomy with removal of the cervix and do not have a history of high-grade precancerous lesions, cervical interepithelial neoplasms, CIN grade 2 or 3, or cervical cancer. All these recommendations do not apply to individuals who have been diagnosed with a high-grade precancerous cervical lesion or cervical cancer. All right, let's have our continued discussion on cervical cancer screening. These recommendations do not apply to individuals with in utero exposure to diethylstilbestrol or those who have compromised immune system. After HPV vaccination, still follow the same age-specific recommendations as unvaccinated women. Diabetes, screening for diabetes. Who should be screened? Asymptomatic adults aged 35 to 70 who are overweight and obese. That's pretty much everybody in the United States. So anybody in the United States from age 35 to 70, they're either going to be overweight or obese. You may have one or two that are underweight or normal weight. Every 3 years in patients with normal glucose. Carotid stenosis asymptomatic patients. So carotid stenosis asymptomatic, meaning they do not have symptoms. It's not recommended. We're not recommended to do screening. Can have a high false positive, may needed for high-risk groups, only 2% difference in morbidity and mortality from best medical practice to getting a CEA. We'll talk about CEAs, but from best medical practice to getting a CEA. Carotid endarterectomy, they're not the easiest surgery in the world and they can have side effects. New studies are still pending and we'll see if we have to update this discussion. Vitamin D screening. The United States Preventive Task Force says the evidence is insufficient to weigh the benefits and harms of routine screening for vitamin D deficiency in adults. Statement applies to community-dwelling, non-pregnant adults without symptoms of vitamin D deficiency. So what can be some symptoms? Bone pain, muscle weakness, or conditions in which vitamin D supplementation is recommended. Aspirin used for primary prevention. Now we talked about this before and we're going to hit this again, and this is becoming important because boards are going to test for it and you're going to get a lot of questions from your patients because guess what? They're going to start seeing there's a lot of stuff in the news and in the news cycle about aspirin. Remember, primary prevention means to measures taken to prevent the disease. They haven't had the disease. Secondary, they've had the disease and now we're moving forward. And we're trying to avoid having a second set of that secondary disease. adults ages 40 to 59 years old with a 10% or greater 10-year cardiovascular risk, disease risk. So we'll see how this does. Right now it's saying to take that. We're going to see over time. We'll see some more studies on that. Low dose individual aspirin is an individual decision. Net benefit is small. So there's a risk of bleeding and the net benefit is small. So we'll see if they're going to continue that. Better for the individuals with low risk of bleeding. The evidence is poor, it's grade C. All right, now let's continue our discussion on aspirin use for primary prevention. Adults age 60 or older recommends against initiating low-dose aspirin for the primary prevention of CVD in adults age 60 or older. Another screening discussion, asymptomatic atrial fibrillation. Not enough evidence for or against screening in atrial fibrillation asymptomatic adults age 50 or older. So in age younger than 55, there's a low prevalence, of 0.2%. But look what happens as we get older. As we get older, increased risk for what? Atrial fibrillation. What's another thing that can increase our risk? Hypertension. And what's another thing? Heavy alcohol use. And they call them, you can have alcohol holidays, meaning that you have heavy drinks during a holiday. You can name the holiday Christmas, you can name the holiday Easter, you name the holiday of being 4th of July, Memorial Day weekend, Labor Day weekend, high alcohol consumption, increased risk of atrial fibrillation. Now here's an interesting one. I promise to give my patients cancer. Remember, the first thing we're talking about, the first thing we do is first do no harm. Let's go with the story right here. This is a 23-year-old female with past medical history of PTSD. Her favorite uncle died of a PE unexpectedly. So guess what she did? She went to multiple facilities in a city, and we know of her having at least 25 CTPs in the last 18 months. Every time she had some sort of feeling, a twitch, any type of thing, she went and she had a CTPE. What does this do? Increases our risk for malignancy. And you can look at this article, it's an older article, but it actually talks about, and there's actually calculators of how much risk, especially in a younger person, to have malignancy older, because they have this exposure to radiation. Now, what is the risk factors? First of all, age. Okay, the younger person gets more CT studies, has greater risk moving forward of developing a malignancy, lymphoma. The type of scan, so the scans themselves PE has one of the higher, just think about if you're radiating the brain, very often can have higher. The type of the amount of millisievert exposure and where the exposure is. Sex, females have a greater risk, and we talked about is that millisieverts, the amount of exposure to radiation. Remember, there's 80 million CT scans annually in the US, and this number is increasing. And guess what? There's expected to be about 30,000 cases of malignancy a year is estimated from CT scans alone in the US. So think about this. Remember, first do no harm, when we did that little oath. We didn't promise to give our patients cancer, but we can unintentionally do that. And we have to think about the effects of this testing that we offer and that we give to patients. That can it cause harm? Can our tests and our efforts to help people cause harm?